Good afternoon and welcome, everyone. I'm Lauren Swartz, the President and CEO of the World Affairs Council of Philadelphia. For 72 years, this council has delivered fresh, nonpartisan civil discourse on critical issues affecting our world. And as we all know, the past year and a half has been, at least we could say, a challenging one in many other things. It's more important than ever for us to keep talking, leaning into new ideas, different ways of thinking, and honing our skills at respectful discussion, even when we don't agree. Perhaps especially when we don't agree or maybe don't understand. And the council is proud to continue these opportunities for civil discourse, albeit virtually. And we thank you for joining us today as a group of thinkers who is hungry to understand the global issues surrounding us. And this afternoon, we're exploring the topic of the ever-evolving pharmaceutical supply chain. The pandemic has brought to light the vulnerability of supply chains around the world. Things like how we source and manufacture active pharmaceutical ingredients, how to increase transparency and visibility in supply chains, and how to ensure that the public and private sectors work together to bring pharmaceuticals to market and meet demand. Before we dive further into our topic, I'd like to offer a special mention to the nearly 3,000 students and teachers who participate in the Council's World Affairs education programs throughout the year. Many of these young people and teachers are joining us today. And we'd like to give a special thank you to our education partner, Temple University's Center for International Business Education and Research, also known as CYBER. Temple's CYBER is one of only 15 centers nationwide supported by the U.S. Department of Education to enhance U.S. global business competitiveness through their programming and research. The Council relies on strong partnerships like this to deepen our community outreach and impact, and we're grateful for 11 years of support and collaboration. I'd also like to thank our event sponsor for today's program, Buchanan, Ingersoll, and Rooney. For more than 5 years, the firm has been a key partner in bringing international affairs education to Philadelphia and beyond through the support of our educational programs, the Council's public television series, The Whole Truth, and critical aid during the early days of the pandemic through the Ed Sattel $1 Million Match opportunity. Today's program will certainly allow time for questions from you, our audience. After opening remarks from our guest panelists and a moderated conversation, we'll move into audience Q&A. So please use the Q&A feature on your Zoom platform to send questions in at any point during our program, and our moderator will facilitate. As always, in our tradition, the first question will come from a student, followed by those from our audience. And now, without further ado, I'd like to introduce our moderator and guest panelists today. We are joined by Matthew Fedowitz, a life science industry lawyer at Buchanan, Ingersoll, and Rooney. Matthew has expertise in the pharmaceutical, life science, and medical device fields, and he focuses his practice on achieving the business goals of his clients. We also welcome today both Jennifer Spalding, who serves as General Counsel and Chief Compliance Officer, and Allan, Senior Vice President for Public Policy at Civica RX, a nonprofit generic drug company founded in 2018 by national philanthropies and leading U.S. health systems to reduce and prevent drug shortages in the United States and their related price spikes. Civica RX's mission is to make quality generic medicines accessible and affordable to everyone. And finally, welcome to Barbara Binzak Blumenfeld, our moderator for this afternoon, and a member of the life sciences team at Buchanan, Ingersoll, and Rooney. Barbara leverages her unique background integrating science and biomedical ethics into her legal practice. And we're delighted that she'll be lending her expertise to guide today's discussion among our panel members. Welcome to you all, and thanks for being with us. I'll pass the virtual microphone over to you, Barbara.
Great, thank you so much, Lauren. I first of all want to thank the World Affairs Council of Philadelphia for creating this platform for us to be able to discuss this very important topic. While the drug supply chain has always had certain vulnerabilities, those vulnerabilities were laid bare and were even magnified once the COVID-19 pandemic began. We all know how difficult it was to obtain supplies such as hand sanitizers and personal protective equipment at the beginning of the pandemic, and we're still experiencing numerous supply chain issues 18 months later. COVID-19 has impacted the pharmaceutical industry in numerous and significant ways, affecting everything from the production of active ingredients and finished dosage form drug products to the transport of medications to where they need to go. Recognizing the challenges faced by supply chains across industry sectors, President Biden issued an executive order in February 2021 that required the Secretaries of Commerce, Energy, Defense, and Health and Human Services to complete a supply chain review within 100 days. These 100-day reviews were released as a single report in June 2021 and cover 4 major technologies and markets, including drugs and drug ingredients. The HHS portion of this 100-day report recognizes that there are 3 critical pillars to a robust pharmaceutical supply chain: U.S. manufacturing capability, diversification, and redundancy. The report extensively outlines the difficulties that this sector faces, including things such as low volumes and profit margins for generic drug companies, cost pressures, distribution contracts that result in consolidation rather than diversification, anti-competitive actions of certain countries, traditional just-in-time inventory management practices, and geographic concentration, to name only a few. In the end, HHS notes that solutions need to improve supply chain transparency and incentivize resilience, as well as increase the economic sustainability of drug manufacturing and distribution, both by the U.S. and our allies. Now, it's important to keep in mind that this 100-day report makes clear that the solution to the U.S. pharmaceutical supply chain issues is not to onshore all pharmaceutical production to the U.S., which would not be practical or feasible. Instead, the goal is to ensure that the domestic supply chain is robust, redundant, geographically dispersed, and aligned with other like-minded allies with respect to competitive practices. So I'm pleased to moderate this discussion today that includes an excellent panel, each of whom is going to address various aspects of this 100-day report and bring their own perspectives on drug supply chain issues. So, as Lauren mentioned, I will first turn it over to our panelists, who will introduce themselves and provide their own thoughts on these and other drug supply chain issues. We'll then follow with a panel discussion and audience questions. So I would like to first of all turn it over to Jennifer Spalding for her introduction. Jennifer?
Thank you, Barbara. Thanks everyone for joining today. I would just like to thank the World Affairs Council of Philadelphia. This is a really timely topic, and even pre-COVID, this has been a problem actually for about 20 years, and that is one of shortages of medications. So our company, Civica RX, was founded by hospital systems to tackle the problem of drug shortages. The hospitals and 3 philanthropic agencies came together to found us and to find disruptive ways to bring these old generic medications that hospital systems use day in and day out to treat their patients, to do routine surgeries. And we have had pretty amazing success with the model that we've put in place to make medications affordable and available to everyone. I'll get into more detail later, but to start, some of the ways in which we've addressed the problem is that we have put in long-term arrangements with our hospital systems and our contract manufacturers to help stabilize the supply chain. We also hold a safety stock of medications that allows hospital systems to feel comfortable that their pharmaceutical company has got plenty of medications in stock, and so they don't have to order just what they need for that week or for that month and hold it, especially a problem in inner city hospitals that maybe don't have literally the physical space to hold medications. So those are a couple ways in which we've done this. And the third way, and probably the one that we're most proud of, is we partner with top quality manufacturers to make sure that the drugs that we provide are safe and effective, and that the supply is stable. We have walked away from potential manufacturers that we didn't feel 100% comfortable with them. We audit them as well as rely on FDA reports. We audit all of our contract manufacturers ourselves to make sure that the quality is going to be there day in and day out. And lastly, from a redundancy standpoint, we are obtaining our own abbreviated new drug applications for many of the most critical manufacturing drugs, and then we will manufacture those ourselves as well. So with that, Barbara, I'll turn it back to you.
Okay, thanks so much, Jennifer. Allan, would you please introduce yourself and give us your thoughts?
Sure, Barbara. Glad to be with you. I'm Allan Coukell. I'm a pharmacist and Senior Vice President for Public Policy with Civica. I don't have to introduce Civica since Jennifer's just done a lovely job of doing that. So let me just take a couple of minutes and talk a little bit about the policy landscape as it applies to supply chain. And first of all, as Jennifer said, we've been grappling with supply chain problems for a long time. The pandemic has certainly brought policymaker attention to it, but aspects of the supply chain were really broken long before the pandemic. So as we think about the supply chain, we need to both think about what policies will create a resilient peacetime supply chain, if you will, that can reliably deliver essential products to the point of care. And then also what will make the supply chain resilient to either a surge in demand or a supply shock, like you might have in a pandemic where you have global increased use of certain products or interruption in production of certain products. And certainly since the start of the pandemic, both the prior administration and the current one have been very focused on these supply chain challenges. In the early days of the pandemic, the Trump administration obviously was reacting quickly to very acute needs, but as time went on, they brought in additional policies around using the procurement power of the US government to support domestic production and other things. And that, as you say, continued really into the Biden administration with the initial executive order and then the 100-day supply chain review that lays out a number of steps, including creating a public-private consortium to focus on advanced manufacturing and prioritize 50 to 100 drugs for onshoring. It also lays out policies around workforce development and a number of other things. And it tasks HHS with a one-year report, which they have been working on, and I expect we'll see fairly shortly, which will add further detail to this administration's supply chain plans going forward. And so, there are a number of kind of big buckets you can look at. What are the tools the government has at its disposal? One is what can it do administratively? And that's always hard because there's not that much money at their disposal administratively, and their authorities are limited by current statutes, but there are things they can do around procurement. There are things they can negotiate around trade law that will change how we think about what is, in fact, a domestically produced drug. And we can talk a little bit about the relationship between domestic production and supply chain resiliency as we go forward. To make major investments, it will require Congress to provide the funds. And Congress has provided substantial sums to shore up manufacturing over the course of the different pieces of legislation that have been enacted during the pandemic. But the Biden administration is seeking further funds in the infrastructure omnibus budget reconciliation bill that, as we know, is sort of being negotiated day by day. And so if there are to be substantial forward-looking investments, it will take Congress to act on that. So that's a brief overview of the policy landscape, and we can talk a little bit more about some of the various tools and policies as we go forward.
Great. Thank you for that introduction, Allan. And finally, last but not least, my colleague, Matt Fedowitz. Would you please take a few minutes, Matt?
Sure thing. Thanks, Barbara, and thank you for having us today. It won't take too long, but I am a shareholder in the Washington, D.C. office of Buchanan, Ingersoll, and Rooney in the intellectual property group. And I assist pharmaceutical companies on both the innovator side and generic side with their IP and patent issues. For the last 20 years or so, I've been living this evolution of the Hatch-Waxman and generic drug industry and seeing how it has really changed over the last 20 years. And so over the course of today, I'll be adding in my insights on how intellectual property and patents affect the supply chain.
Great. Thank you, Matt. So what I'd like to do then is, as we mentioned, begin sort of a moderated discussion here. I may throw out questions to certain individuals, but I'd encourage everyone on the panel to weigh in if you want to. I would certainly welcome that. Jennifer, I want to start with you. You raised a very interesting point in your introduction. You mentioned that your business model could be considered disruptive, and I love that word because your company had such unique origins. So I'm wondering if you can expand a little bit more on your business model, but also, in your relatively short lifetime of just being around for a couple of years, what have you learned about your efforts, and how has the company incorporated what it's learned into its overall business model and goals?
Great question, Barbara, and thank you. Let me tell you first what we think is unique about our business model. And there's several pillars that have made us very different, and I think helped to really provide these medications to our hospital systems. The first and probably most unique is we are a not-for-profit entity. So we do not have shareholders that we have to keep happy in the sense of return on investment. Every penny we make, we put back into R&D. And even more importantly, we try to keep the cost of our medication as low as we can. But some of the ways that we've operationalized our business model is to have long-term take-or-pay arrangements. So we have 50 plus hospital systems as members in Civica. That's about 1,300 hospitals. And each one of those can choose to commit to purchase up to 50% of the medication that we bring forward. So we want to continue to see competition. They can buy the other half of their needs on the open market through their GPO contracts, but we ask them to commit 50% to us, and that's for 5 years. And what that does is that allows us to then go find a supplier in these early days and commit that volume to them so that they know I will have X amount of volume needs so that I can invest in my manufacturing facility. I can hire the people that I need. And what we have seen and why this is different is GPOs have historically done a fabulous job of driving prices down. But on these old generic medications that aren't particularly expensive, the price in some instances has gotten too low. And they just continue to rebid to the most aggressive supplier. And so it has made it hard for manufacturers to have some consistency in demand. And we've seen some get out of the market and manufacture more lucrative products. And what happens when you reduce that competition is, unfortunately, you see price spikes. So if you've only got 2 players in a field and someone has a manufacturing issue, the other guy is able to charge whatever they can get. And we do not change our prices. Our prices are firm for 5 years. And while it might not be the lowest price that they can get out there, they know that it's going to be the same over time, which brings some certainty to our hospital systems and to our manufacturers. And the last thing that I would add to this is that we have disrupted the market we don't pay GPO fees and we don't use traditional wholesalers. That allows us to charge one price to all of our hospital systems. So typically in the hospital space, the biggest hospitals get just great rebates and discounts that bring that price down. And your smaller facilities unfortunately pay a much higher price. And what we've done is we've set one sustainable price to everybody, regardless of size or volume commitment. And that really, we feel, provides a fairness to all of our members that allows them to have some certainty that the medications that we always see going on and off the drug shortage list will be stable for them.
Yeah, that's great. In that vein, I want to follow up with a question for Allan. And what's interesting is that this 100-day report notes that regardless of the sector we're talking about, and there were numerous sectors that were addressed in the report, that the way the U.S. market is structured, it doesn't necessarily reward firms that invest in quality or sustainability or long-term productivity. So I guess building on Jennifer's initial thoughts, you know, how are you hoping to challenge those notions? You know, it sounds like you are hoping that through these arrangements that actually quality can be built into the system.
Absolutely, Barbara. And I think the 100-day supply chain report is a really superb diagnosis of supply chain weaknesses. And I'm glad to say that, you know, I opened by thinking about both a peacetime and a pandemic supply chain. And the 100-day report really goes through both those scenarios. And it lays out solutions in some areas, but not others. And I think that's partly because FDA was the lead agency in writing the pharmaceutical section of that report. So there are places where, for example, the report recognizes the risks associated with a just-in-time inventory, but there isn't a recommendation in the report for that. So what's Civica doing as an organization that was created to really create a more resilient supply chain for the hospitals we serve? Well, we keep a physical inventory of several months' supply of all of our drugs on hand. And so if there's a surge in demand, as we saw early last year, we have drug in a warehouse that we can ship. And indeed, we saw overnight a 300% increase in demand across our systems for some drugs last year that we were supplying. Similarly, if there's a supply interruption, we have a reserve supply that can tide us over until a manufacturer can increase production. And so that's the kind of thing that we think really needs to be translated system-wide. Maybe not for every drug, but certainly for a subset of drugs that we think are at risk, maybe the drugs on the essential drugs list, for example. But we have to recognize there's a cost associated with doing that. And for Civica, we tie up a chunk of our operating capital having drugs sitting in a warehouse. And we do that because we're a nonprofit and we have a mission around supply chain resiliency. But no one else in the system has an incentive to do that. And yet, you know, pharmaceutical production is relatively inelastic. If there's a halt in production due to a quality problem or a trade war or whatever, it's going to take some months, best case scenario, for production to come up. And so we have to address that inventory. Actually, Australia has just put in place an agreement or a policy with the pharmaceutical industry there that will result in 2 quarters of drugs being kept on hand at all times. So right now we haven't tackled that in the US, but that's one example. Another is that Civica has a really robust process of qualifying our suppliers, of doing physical inspections of the manufacturing premises, of looking at their any deviations from quality, any audit reports, and so on and so on. And we have a list of metrics that we require from any company that's a supplier. The 100-day supply chain report called for the government to issue what's called quality maturity ratings, which would really be a way of going beyond the current situation where right now a drug is either approved or not. And other than that, the purchaser doesn't have much ability to distinguish the quality that is behind that. And so a quality maturity system would let the FDA or potentially some other entity really say, how well does this company do on quality? What's their culture? What are their processes? And then it would sort of give purchasers a tool to move away from this race to the bottom where price is the only determining factor, to say, let's direct some or all of our purchasing to manufacturers that have higher quality maturity ratings. So that's something the FDA has been working on for years, but this administration has now said it's a priority. So that's a couple of examples where I think there are some lessons in the Civica model that we could sort of translate over system-wide.
Great, yeah, thank you. Yeah, I was very intrigued by that that mention in the report that you just said, Allan, about kind of this quality ranking system. I guess one of my concerns is, and there were no details that I recall really being provided. It's an intriguing thought, but I think my concern would be, how is that updated, and does it reflect sort of real-time data? Because we know that things can change and that companies can have a blip, they can have an issue, then that can be resolved. Any thoughts from anyone, or Allan, or how that would work in reality?
Sure. I think it's, you're right. It's not easy, and FDA has been working on this question for a while. And over time, they've really moved from the idea of quality metrics to a quality maturity rating. And I think that is something that does get you at that sort of longer term question of where are companies that really walk the walk, that take quality seriously, that have not just policies on the books, but really everyday policies and practices and a culture in place that emphasizes quality and puts quality above other things. And I think that aspect, quality maturity, is something that doesn't change quickly. If it's not there, it's not there. And if it's there, it takes time to go away. So I think by really shifting towards a quality maturity system, we're getting at that question that you raise.
Yeah, great point. So what I'd like to do is just shift gears for a moment. I want to ask Matt a little bit about the role of intellectual property in this. And the first question is pretty basic. Did this 100-day report say anything at all about the role of intellectual property? And do you think it should have said something?
Thanks, Barbara. So yeah, I was reading through the 100-day report, and surprisingly, there were very few mentions of patents and intellectual property and all of that. And thinking about the issue more, I didn't think it was that surprising, because I think the Biden administration is addressing issues with regard to patents and supply chains through IP and patent waivers. For example, there's a lot of international discussions going on now with regard to COVID vaccine waivers on patents that cover processes for making this. The current status is India and South Africa put forward a joint effort to implement these patent waivers. Since the U.S. is such really a hallmark country as far as maintaining strong intellectual property, I think the Biden administration has not really pushed forward with this. And so they've taken sort of a middle row seat at the WTO in regard to this. So I think, to answer your question, yes, there was not much discussed in the 100-day report. However, I think it's being addressed in a different channel.
Okay, so to follow up on that, I know a lot was made in this report about the sourcing of both active ingredients and finished dosage forms, and how, really large percentages, often, 80, 85% plus of active ingredients, for instance, come from overseas. And so I'm wondering, in the context of drug production, with respect to changing an active ingredient manufacturer, let's say you have a problem, you need to make a change in sourcing. Does this create a significant hurdle in order to recover from a drug shortage if a company already finds itself in a shortage situation?
Yeah, Barbara, you're absolutely right. What happens when a generic drug manufacturer is putting together their abbreviated new drug application is they reference a specific active pharmaceutical ingredient, which is the active ingredient, which gives the effect. And that's usually approved by the FDA, and there's something called a drug master file that guides what that product is and the details about it. So that drug master file is referenced in the ANDA, and say if there's a problem with the production of that active ingredient, what ends up happening is it's not that easy to just switch. To change a DMF from one manufacturer to another, or change an API from one manufacturer to another, what has to be done is there's something called a major amendment to an ANDA, and that can take the ANDA offline and increase the likelihood that there would be no supply just because that change is being made. So I think there's been some discussions about maybe relaxing the regulations with regard to amendments to ANDAs to help this. But that would be a major hurdle.
Okay. And then I guess finally in that vein, with respect to IP in particular, are there patent issues you're aware of that actually relate to active ingredient suppliers in the supply chain?
Yes, absolutely. So what has happened over the last 20 years, as I mentioned, the active ingredient suppliers or the API suppliers have really become sophisticated. And what I mean by this is that these active ingredients, are, for instance, the chemical molecule, and that chemical molecule has to be a solid form because that's how it's used usually. Those solid forms can take on different crystalline attributes or have different and specific chemical characteristics. And what API suppliers, sophisticated API suppliers have done is they've gone and gotten patents on these different types of the APIs that they supply to different finished dosage form manufacturers. So what can happen is, say, as an example, say one API is being supplied to a single manufacturer, and then there's an issue with, like we mentioned a moment ago, say they would like to switch or make another form of use a different form of the API. If another API that's available is under patent, then they may have to pay a higher price for that. Or for instance, if a competitor is using that API, which is patented, and another competitor is using an unpatented form, if the unpatented form goes offline, then that one generic manufacturer using the patented form can take over the entire market. And as Jennifer had mentioned earlier, they could charge as much as they want because there's less competition. So there are a lot of issues there, and it's something they really keep in mind as far as choosing an API supplier, what the landscape is, what the IP landscape is as it relates to APIs and things of that nature.
Okay, great. Thanks, Matt. So Jennifer, I want to go back to you for a second. In terms of the sourcing of your medications, I had mentioned earlier on, and the report is clear that we can't expect everything's going to be made in the U.S. It just has to be. We have to have a robust, redundant supply chain. So in terms of Civica, do you source all of your medications from U.S. suppliers? And I guess what have you seen in particular, and how have you adjusted in the last 18 months during COVID?
So Civica does supply as much as we can from manufacturers in the U.S. We also have some very reliable suppliers in Western Europe. And India, we have a supplier or two in India, but that's a great example where COVID hit India in a way that really shut them down. So not that it was any nefarious act on behalf of any of the manufacturers, people just couldn't get to work. And so you saw that there was a disruption from ingredients coming out of India and governments not allowing exports because their own people needed medications. So while we definitely need, and I think you put it right, Barbara, we need diversity of supply. Unfortunately, when it comes to the active pharmaceutical ingredient, that sometimes is a little harder because there's price is just such an important component, and countries that don't take some of the EPA restrictions and environmental concerns are able to produce medication, API in particular, in a very low cost way. And so that's not good for, frankly, anybody. But those are some of the things that I think with some certain advances in manufacturing capability of API, we'll be able to bring some of that back to the United States and hopefully other countries that can use more of an advanced manufacturing capacity that has less environmental impact and less waste, and frankly, lower cost because it's a faster manufacturing process. So we're starting to see that investment in the technology, I think, will help improve some of those things. And then, like I said, sometimes we just need more than one supplier, and we're building our own manufacturing facility that will help us have, for some of these that we've seen a lot of problems on, we'll have two sources. We can manufacture it ourselves, and we can also rely on third-party manufacturers as well. Allan, anything that I missed in that answer?
Off mute. No, I think that was a great answer. And, you know, as you say, we're heavily dependent now, the whole world is on China for API. And that's for the same reason that manufacturing of iPhones and everything else has gone to China. It's lower labor costs, a very favorable regulatory environment, in some cases perhaps lower environmental standards. And so as we think about diversification of API, it's really important to look at not just the number of manufacturers, but also their volume. Because if there are 5 companies in the world making a given API, but 90% of the volume comes from just one of them, we're still at great risk.
Okay, yeah, very, very good point. So Jennifer, one follow-up on that. So, you know, we've been talking about manufacturing and sourcing, but you know, the supply chain just doesn't end there with the manufacturing of the finished dosage form, of course. So I'm wondering what you have seen in the marketplace about the supply chain and any difficulties that have arisen as it actually goes from, you know, warehouse over to the actual recipient, you know, your hospital customers.
Actually, as we have all been so thankful for Amazon, as we've not been able to go to grocery stores and the other retailers, it's really stressed the domestic supply chain in terms of literally just trucks and trains to get products from point A to point B. So whereas a lot of, you know, there's just been such a massive increase, we have seen some difficulties, and our hospitals have seen difficulties across the board in making sure that their medical devices, their pharmaceuticals, their PPE, everything that they get has suffered, as well as, you know, it used to be you had no concerns when you ordered something online that it would be there in a few days. And as consumers of just everyday things, we've seen disruption, but we've also seen it on those more life-sustaining things like medications. And I do think that the market will start to catch up, if you will, but it's not an overnight process. We've seen just production in cars, right? It's hard if you've been in the market for a used or a new car, it's kind of hard to get one right now. And of course, we saw the incident with vessels when, you know, the big the shipping vessel was stuck in the Suez Canal. So you've seen all these different things that have impacted the supply chain in very unanticipated ways because of COVID. And I think we have seen a shift in how consumers expect things to get to them that probably will not fully go back to where it was. So it'll take some time, I think, for the supply chain as a whole to adjust to sort of the new world economy that we're in.
Fair enough. Yeah, great point. I want to jump back to Matt for a second because you were talking earlier, Matt, and as I've been thinking about it, it seems like there's really an inherent tension sort of between increasing the supply chain, but then, you know, some of the pressures on the generic pharmaceutical industry. And we know that there are cases when there are multiple generic, what we call first filers, that want to come to market when certain patent protections are close to ending. So what do you think is the impact of these multiple first filers in the generic drug and ANDA space? And how is that impacting the whole discussion?
Yeah, sure, Barbara. So that's a really interesting area because just for background for everyone who doesn't do Hatch-Waxman or ANDA litigation, this webinar. What happens is there's a certain point in time when a generic manufacturer can file their ANDA with the FDA, and it results in a litigation going on. Typically, when you have a new chemical entity or something like that, you can file your ANDA a year before that exclusivity expires. Then what happens is you have a litigation that goes on for about 2.5 years, and over the course of that litigation, it will go to trial sometimes it won't. Sometimes there'll be a settlement in the case. But when you have these cases where there's perhaps a big blockbuster drug that everyone's looking at to get in on the market, you'll have, as you mentioned, Barbara, multiple first filers. The issue is when you have 20 or more first filers, you have way too many manufacturers interested in making a product than the market will handle. And it will essentially dilute down the share of the pie that each of those manufacturers could reap some sort of profits from, even with incredibly slim margins. So what happens then is, they recognize what's happening with the market. And some of these manufacturers won't even go on the market. They'll just, put their hands up and, settle out of the case and then just move on to another product that might be more profitable. So what you have ultimately is, even though you might have a lot of interest from several manufacturers to make a product, it's just not even worth the effort, and the market's just not there to sustain them putting a product on the market.
Yeah, which is a really fascinating consequence, because the whole goal is to try to increase competition. But as we know, profits can be driven down, and so you almost end up in a counterproductive situation, which it leads to perhaps unintended consequences. So what about settlement agreements? I mean, we hear about generic drug settlement agreements from the litigations, and can you offer any more thoughts on those impacts? I mean, I know that there can even be Federal Trade Commission implications, not that we need to get into that, but can you offer a few more thoughts on that?
Right, and so a little while ago, I mentioned that there can be settlement agreements at the end of these cases where they don't go to trial. And sometimes what ends up happening is the innovator who owns the patent and the generic manufacturer reach an agreement where they say, okay, you can put your generic product on, perhaps 2, 3, 4, 5 years in advance of the patent expiry. Okay, so when you get to that point in time, the ANDA has its final approval, and it goes, the generic manufacturer can start marketing their product. However, if there is an issue with the supply chain for that generic manufacturer, there sort of a false reality may take place where you would think someone else could step into their shoes and start supplying the generic form of the product rather than going back to the brand form. Since the access to the market is guided by that settlement agreement, no one else can really get in there unless there's another party that has a similar type of agreement. So you can have these scenarios where you have an innovator facing generic competition for a certain amount of time. The generic manufacturer faces some sort of supply chain issue. That comes off the market. The only thing you have then is you're back to the brand only, or maybe one of the other generic manufacturers who's not facing as much competition. So you have this false reality of competitors replacing each other if there is a supply chain issue.
Yeah, that's a great explanation, a great way to put it. Allan, I want to jump back to you, because I know that you were mentioning initially some policy initiatives and the policy implications of this 100-day report. And we know that there's a policy focus on the domestic drug supply chain for a lot of reasons, which we've been discussing. But there's also been this development of this essential medicines list at FDA. And I'm wondering what drug products, if we're talking about onshoring things that are essential, how do we determine that? I mean, how does FDA determine what's essential? That you mentioned a public-private consortium that may be then further narrowing that. I mean, can you offer some more color on that process, or your thoughts on it, and who should actually be at the table making those kinds of decisions?
Yeah, it's a great question. And it's fair to say that every drug is essential to somebody. And so when we're thinking about how do we use policies to really ensure that we have resiliency or targeting bringing some drugs back to the US for domestic production. And as you said in your opening remarks, we can't bring them all of them back overnight. So how should we set those priorities? So the FDA essential drugs list is really kind of a public health emergency drugs list. It's the drugs that you use, it's antibiotics, it's the drugs that are used in critical care, in surgery. It's sort of the bread and butter of the drugs in a way that underpin kind of acute medical care. And I think that's a very practical way to approach that list. Now, as I say, what else is an essential drug? Well, certainly, a pediatric cancer drug is essential. An oral contraceptive is essential to somebody. But in terms of thinking about where do we make targeted investments, that's probably the FDA approach is probably a way to approach it, to sort of begin to not boil the ocean, but say, where are the products that in a public health emergency we could see a demand surge and or every company essentially protecting their own population. And at the start of this pandemic, we saw a number of countries put export restrictions in place. And that's, when we talk about domestic, that's one of the things that we're trying to guarantee against, is a situation where other countries are making that drug, but they're keeping it understandably for their own citizens. Where are the ones where we want to have some capacity here? And then I would actually suggest overlaying kind of a set of factors on that, thinking about, all right, so what are the drugs that you could have a surge in demand during a pandemic? And then what are products where we have an overwhelming dependency on one source, either one company or one geographical location? And it doesn't have to be foreign. We saw in this country a number of years ago, and sort of continuing to this day, huge problems with IV solutions after production in Puerto Rico was halted by a hurricane. But as we say, there are drugs that are heavily concentrated in one part of the world or another. And then what are products where we have absolutely no US capacity? So where we're not making them at all here, and in some cases where you couldn't make them. So we look at, for example, penicillin and cephalosporin antibiotics are a category of products that need dedicated facilities because so many people have allergies to those drugs and their sensitizing agents. So nobody makes them in the US right now, not the active ingredient, not the finished drug. And you couldn't take an existing pharmaceutical facility and press it into service to make those drugs. So that's a vulnerability. And then the last factor that I would overlay there is, what are products that already have a history of supply problems? So where are ones where we have seen them be on the shortage list on and off for years, i.e. where the supply chain is already demonstrably fragile. So I would suggest those as a list of factors that could be applied as we begin to say, how do we dedicate limited resources to really prioritizing certain products?
Okay, excellent thoughts there. What I want to do now, since we're at 12:47 here and we want to make sure we have time for Q&A, is I want to kick off the audience Q&A with a question coming from Corey Stubanis, who is interning with the Counsel in the Programs Department and who graduated in May of this year. Congratulations. From a dual program at the College of William and Mary and the University of St. Andrews in Scotland. And he is joining us to kick off our audience Q&A portion. So Corey, welcome, and please go ahead with your question for the panel.
Thank you. Yeah. As was touched on earlier in the program, the Biden administration 100-day review identified increased domestic production, growing the number of suppliers, and redundancy as ways to make the supply chain more resilient. How difficult do you predict it will be for the pharmaceutical industry to shift towards a less specialized and less internationally reliant model? What new benefits and costs do you think this policy will have for companies?
Oh, thanks, Corey. Well, that's a pretty loaded question. So I'm going to leave it to our panel. I'm not sure who'd like to kick it off, but I want to make sure everyone can chime in who would like to on that one. Allan, I see you unmuted yourself.
Sure, I'll go first. I think it takes a substantial capital investment to create new manufacturing capacity. And as Matt has already referenced, it's a non-trivial process to develop a product, even a generic product, and file the ANDA and so on. So for any company that already is making a product somewhere in the world and has an approved ANDA, they're not going to change their production methods or their production location lightly. It's non-trivial. And so that's why we really need to be thinking about what are the products that we want to target. And we need to recognize when it comes to domestic manufacturing that production has gone global for very good economic reasons. And that if a company is looking at making new capital investments to make a product in the US, in some cases, that just won't be competitive, just won't be. And that's where I think in a judicious way, we have to think about what are the products that in the public interest we really want to make here. And it's going to take a public investment along with private industry to help make that possible. I don't know if anyone else wants to jump in on that question.
I'll jump in. I think it actually allows for a really unique opportunity. So earlier, Jennifer and Allan mentioned having to put together new manufacturing sites that are more efficient and are guided by the regulations in the US. And so I think this presents an opportunity where if more efficient processes are developed to make certain products, whether they be API or finished dosage forms, that are within the guidelines in the US, those processes could be patented. And once you patent those and you get your patent issued from the USPTO, then you can stop others from doing that. And it may present a unique opportunity where that generic company making their product in the US has pinned down a process that works in the US and could potentially license it to other competitors. So I think there's an opportunity there that might not be right at the forefront, but it's something people should keep in mind.
Great. Anyone else want to add anything? Otherwise, we've got a number of great questions coming in, which I'm happy to jump to. Okay, well, thank you, Corey, for asking that. We really appreciate you being here.
And thank you for the detailed answers.
You're very welcome. So, okay, we have a number of questions coming in, so I'm going to try to tackle these, at least as many as I can in the time remaining. So one of them is interesting and touches on counterfeit drugs. It says, with the problems and delays already experienced with the supply chain, as well as some of the higher costs for consumers that are likely to result from some of the 100-day report recommendations, such as buying American or increasing regulation, is the counterfeit drug market a concern?
So I'll take a stab at that one. I think it's always been somewhat of a concern. There is a gray market out there for things that you would really rather not see a gray market for. I think that, and this is more in Allan's space, but that might be something that the government may want to look into. With some of the Drug Supply Chain Security Act going into effect, which keeps being delayed and delayed, but once that's in effect, I think that could be a really nice way to help ensure that you know where the particular bottle has been along the supply chain, whether it's stored appropriately within the temperature control, that it's not, hasn't been sitting somewhere that has not been sanitary, those types of things. So while there are things in place, I would like to see some of that accelerated in terms of, particularly in the Drug Supply Chain Security Act, because when things get tight, there's always that temptation, the supply and demand problem, right, of less than ideal supply chain for medications.
Yeah, good point. And anyone else want to jump in on that one, or otherwise I will move on to the.
Well, just to follow up on what Jennifer said, where have we most recently seen these sorts of problems? It was with PPE and hand sanitizer and some of the other products, where there was kind of a run on products at the start of the pandemic. So counterfeits in the U.S. have tended to be either online pharmacies or really scurrilous but peripheral players in the wholesale drug distribution market. That's where it's been, at least historically. And so, well, for the most part, the supply chain in the U.S. is very robust. Following through and getting the serialization and tracking requirements in place should do a lot to foreclose on those opportunities.
Okay, yeah, great feedback. All right, let's see. We have a very open-ended question here, I would say, but I will throw it out there. It says, when are we going to be, quote, back to normal? Or perhaps back to how things were in the pharmaceutical supply chain 3 to 5 years ago. So I'm sure that the focus is, pandemic versus post-pandemic era. I'm not sure. It's a good question. It's challenging because what was normal, and is normal what we aspire to go back to? So those are my little twists on that question, but I'd welcome anyone's comments on something like that.
So I'm happy to take a stab at it, knowing that my crystal ball is not very accurate. I would venture to guess that COVID's sort of with us, and we will have to learn to work with it as vaccines continue to improve and adjust to new variants. But in terms of the supply chain, I think I'm headed where Barbara is, and I'm not sure we want to necessarily go back to normal. I think this might be an opportunity to improve our supply chain. Things that we are learning today in terms of, how best to move product, how to diversify, and frankly, the value of the distribution network. It has been largely undervalued. You think, that you're a Prime member and your stuff gets moved free through Amazon. Drug wholesalers, I was there for a number of years. Everyone thinks that the work that they do is free, but that all of those things and those conveniences that we rely on, we have undervalued. And I think part of the breakage that we've seen is a result of us not accepting that there's a true cost to doing business, and we need to factor that in. Not saying that there isn't maybe some fat in the market, but we also need to recognize that we really do rely on the supply chain, and we should be willing to pay for the legitimate services that we get when moving our stuff around. So think of that next time you get your Prime membership. I sound like an Amazon commercial. When that comes through, like it really is a huge value to us. And so that was my stab at it. Others?
Yeah, I'll agree with you, Jennifer. I think it's going to be an evolved scenario. So I don't think we're going to go back. I think we're going to evolve and become better. And all of these weak links that we've discovered over the last year and a half are going to just be better in the future.
I agree.
Okay. Well, we have two questions here that are related to the role of China. And so I'm going to read them together and then just say, whoever wants to comment on either question, we'll do it that way. So the first question was, has China's Belt and Road Initiative extended to the pharmaceutical manufacturing industry? And if so, what impacts has it had on the global market for pharmaceuticals? So that first one was about China's Belt and Road Initiative. But the other one is, to what extent does the Biden administration intend to reduce China's component of our drug supply? And is there conversely going to be an intent to increase, for instance, with some of our more local partners like Mexico and Canada? So there's a lot to unpack there, but I guess the key is what's happening with the role of China, and how does that relate to maybe trying to increase the role of other countries?
Well, I think the big picture answer first, which is I do think in a bipartisan way in this country and also in other countries, there has been a shift in the past couple of years to recognize that the strategic posture towards China is going to have to evolve and prepare for a situation where China is not an ally working hand in hand in the sort of global trade alliances the way a few years ago, I think that was probably the dominant strain in foreign policy. And then as we look at drugs, as we've said, China has invested heavily, and the state has strongly encouraged and in some cases directly subsidized China to become the major producer of API in the world. They're now also looking to sort of move upstream in that manufacturing process and make finished drugs, the tablets and vials and so on in China. So those two things are happening in parallel. So I think the risk of depending on China, both because of very high profile quality problems we've seen around, for example, the intentional adulteration of a blood thinner heparin a few years ago, but also around dog food and other products, as well as the threat that Chinese officials have made to use drugs as a weapon in a trade war, have caused a renewed focus on our dependence on those sources of supply. And I think that's part of why you're looking at the administration, which is looking at both domestic capacity, but also looking at working with our close allies to ensure resiliency.
Yeah, great answer. Anyone else want to offer any thoughts on that?
Sure, Barbara. So I can speak to Mexico. The Mexican pharmaceutical industry is very sophisticated. I think the dynamics of the pharmaceutical industry there, though, sort of points them to supplying more of Latin America than the US, especially given the complexity of our system here compared to the system there. And so I think, like we're talking about the evolution of the pharmaceutical industry, I think you're going to see the evolution of Latin American pharmaceutical manufacturers taking an interest in putting their products on the market in the US. And I think not only does this give them the opportunity to perhaps, take their share of the US market, but also at the same time, they are trading partners. And also by them having FDA approved products will allow them to sell probably more products in Latin America, because they can say that. They can say, look, we manufacture products that are approved by the US FDA, so you should buy ours instead of our competitors. So I think there's a number of opportunities for Mexican pharmaceutical manufacturers, and I think we'll see this evolve.
Okay, great. All right, I will move on to yet another question we have. And this question asks, do we think the right steps are being taken to update the US government stockpiling strategies and protocols? What else can be done to ensure preparedness for the next pharmaceutical crisis?
I can jump in on that. So the kind of classic government stockpile model was a warehouse full of product that sat there until it was needed. And when there was an emergency and it was needed, the federal government drop shipped pallets to a state, which then distributed the product as needed within the state. And that's clearly a system that's set up for a very short-term event and very kind of geographically limited event, and not well adapted to a pandemic, which goes on for months or years, and where the product's really needed everywhere at the point of care. And so we have seen the government begin to sign contracts and move towards more of a vendor managed inventory, where rather than the government having a warehouse full of product, it's sitting, with the wholesaler, and they're keeping surplus, and that lets you have a flow through inventory where older product is sold into the system and continually replenished at the other end with newer product. And so they're moving in that direction, which is a good thing. It's something, it's what Civica does with our own stock, and we've advocated for. It's still, I think, a work in progress, and in some of the documents that are coming out of the administration, you're seeing a lot of talk about control tower structures, which will give the government much more insight into where inventory sits at any given time. And so I think it's still evolving, but they have moved towards a stockpiling system that's much more able to deliver product to the point of care on an ongoing basis.
Okay, great. Anyone else want to offer thoughts? Otherwise, I'll just remind the audience, we've still got some time. Otherwise, I still have a couple of additional questions that I'd like to ask as well, but I would rather make sure all of your questions get answered. So if you do, please continue to submit those for the next few minutes. So Matt, I want to jump back to you on one key point that we've been talking about, and that's really the interplay between patent law, FDA law, all of these areas really merge together. So I'm wondering, to what extent have there been any discussions between FDA and the Patent Office, for instance, about how they might work together as kind of sister agencies to increase generic drug competition? Oh, Matt, you're still on mute.
Sorry about that. That's a good question, Barbara. Recently, there was a letter sent from FDA to the USPTO, because we have to realize these are two separate agencies that don't necessarily talk to each other. However, I think given the concern about what patents are covering certain innovator products, should there be patents there at all? The strains on the U.S. Patent and Trademark Office and the examiners who are reviewing the patent applications. I think there's some policy concerns there as to what type of patents are being issued. I mean, if we think about it in its most basic sense, a patent is basically a monopoly, a government granted monopoly for a certain amount of time to stop other people from doing something. And so, yes, in this letter that was sent from FDA to the USPTO, they talked about some cross-training initiatives between FDA employees with Patent Office employees to better understand the examination process, and perhaps to aid in that examination process by providing access to different databases and technical computer systems and things like that. There's also been an effort to understand what the Patent Office's perspective is with regard to the misuse of patents. How are companies or individuals using patents in certain ways that maybe would be frowned upon? And then also, one of the things that's always a chief concern, especially with these complex pharmaceutical patents, is patent examiners at the Patent Office are not given as much time as they want to review patent applications and issue them. They're given a very short amount of time to take what they see in front of them, digest it, understand it, and determine whether there are any problems with it. So this is difficult, and it's a problem that sometimes results in bad patents being issued, which have to be resolved after they're issued. So should patent examiners get more time to review these patents? And so this is something the FDA is concerned about, especially in regard to pharmaceuticals and biotechnology. And then finally, we're familiar with the FDA's Orange Book. And for those who are not, what it is for all of the approved drugs in the US, they're listed in something in the FDA Orange Book, which is literally an orange book. But that Orange Book also contains patent information for those drugs that still have patents covering them. And the FDA does not check that patent information. They're just sort of a holder of it, the publisher of the information. Really, they're relying on the patent holder to list correct information in there. So there is some concern about working together with the patent office to determine whether patents that are listed in FDA's Orange Book should really be there. So those are the 4 areas that there is some discussion that's going to be had, and some more evolution as we talked about over the next several years.
Okay, excellent. And I think that's a great segue, because I think it's clear that this is really a multifactorial problem that's going to require a lot of things, perhaps legislative change, regulatory change. I mean, there's a whole host of issues we didn't get into, which apply across sectors, which the report identifies. Things like just making sure we have a trained manufacturing, pool of people here in the country, and dealing with wages, and there's a million different things that are at play. So before we wrap up today, then what I just want to do is give everybody, the opportunity on the panel here for in a minute or so to offer any closing thoughts. Perhaps thinking about what do you see as the best next step for the administration and HHS as they look to roll out more details. I'm just going to leave it very open-ended, but I'd love everyone to offer some parting thoughts, if they will. And I'll just go in the same order that we introduced ourselves, if that's okay. So Jennifer, do you have any closing thoughts?
So I'll focus on, I guess, the free market fix to these things, and leave the policy to my colleagues. But I am hopeful that there will be more entrants into the pharmaceutical space that are looking for maybe not just bottom line. There's a new legal structure that is a public benefit company that allows shareholders to make sure that a large part of the focus of a company is for a public benefit and not just shareholder return. So I think that I am hopeful that maybe Civica is starting to demonstrate some new ways that people can be successful in business, because I'm a firm believer that we have just millions of incredibly smart people here that hopefully will find a path forward to make healthcare a little bit better, even if it's just one little piece of the puzzle. So I'm hoping we'll start to see additional new and innovative business models that will help to solve many of the problems that we see in the healthcare and distribution market. That makes me pretty hopeful that there's a brighter future. So with that, I'll turn it over to Allan to maybe speak a little bit more about what the government might look to do.
Thanks, Jennifer. I'm cautiously optimistic, and let me tell you why. First of all, this is a policy area where we've actually seen surprising continuity between the Trump administration and the Biden administration in terms of the problems they're recognizing and the tools that they're proposing to use. And we don't see that everywhere. And there are a number of things that this administration can do administratively around using federal procurement to incentivize domestic production and supply chain resiliency. We've already talked about some of the changes that are already happening in stockpiling. They have talked about revisiting certain agreements with trading partners. They have created this or plan to create a consortium that will prioritize certain drugs. And there have been some investments in new technologies for updating manufacturing and so on. So those are all things that can happen administratively, more or less, with current budgets. And then there is this substantial budget request to Congress. Now, nothing in Congress is easy these days, but public health and FDA policy have historically been an area where bipartisan cooperation has been possible. And we certainly see members of both parties focused on these issues, introducing bipartisan legislation. And we have a process that Senator Murray and Senator Burr, the chair and ranking member of the Senate Health Committee, which oversees all of the relevant health agencies, FDA, ASPR, BARDA, CDC, have launched to review public health supply chains. So, with the caveat that nothing is easy in Congress anymore, I'm cautiously optimistic that we will see real meaningful progress here around supply chain resiliency.
Great, thank you, Allan. And Matt, any
Sure.
closing thoughts or things you wanted to talk about that we didn't have the chance to?
Sure, I'll just take a moment here, but I think with this evolution and all this change, it presents a great opportunity to identify what is next. And whoever identifies what's next is going to be able to take advantage of that and get out ahead of it. So I just think it's a very exciting time. I mean, it was thrust upon us with COVID-19, but to be able to turn this around, turn it into something new and better is just really exciting. So I'm looking forward to seeing what that is.
Great. Well, thank you, Jennifer, Allan, and Matt for being wonderful panelists, and I really enjoyed our discussion. I'm going to turn it back over to Lauren for any closing thoughts.
Great, thank you, Barbara, and to our panelists and our audience today. This was a fascinating discussion that I hope, well, it was very complex, gave us some ideas for the future and where we're headed, which is exactly what we like to do here at the Council. Thanks again to our partners at Buchanan, Ingersoll, and Rooney and Temple's cyber program for helping us think big about what our society needs to impact this daunting and exciting world before us. I hope all of our members and audience today enjoyed the program and found things that they can learn and view things through a new prism of thought and formed some new ideas going forward. Please continue to join the Council for our upcoming events. Next Monday, we have a virtual program on the global movement for Black Lives with a panel of activists and academics from Brazil and Germany and Canada, moderated by 6 ABC News' Christy Aletto. Also this fall, we've got in-person conversations about Israel and Hamas and the Middle East, as well as a conversation club. And we're excited to be hosting the former president of Chile and current UN High Commissioner for Human Rights, Michelle Bachelet, among many others. You can find all of that information and more at our website, wacphila.org. Thank you all for joining us and have a good afternoon. Bye-bye.